Today's Fern educational session involves critical long COVID symptoms, brain fog and headache, fatigue and weakness, and chronic inflammations. What are their pathologies, how to clinically diagnose these patients, and how to optimize patient outcomes. My name is Edward Sloan. I'm Professor Emeritus in the Department of Emergency Medicine at the U of I in Chicago, and I'm Medical Director of the PA Studies Program at Dominican University in River Forest, Illinois. I am Fern President and Board Chair. I have no financial conflicts. You can find this information on our fern.org website and our YouTube channel at fern.org. This is a screenshot of our playlist page. I encourage you to go there for more neurological emergencies information. This is my contact information QR. So in conclusion, as we have discussed long COVID patients and ways in which to optimize their recovery, we conclude the following. Regarding COVID-19 pathology, we know it is a viral infection that causes secondary infections. We know that there's direct neuron and CNS tissue toxicity. There's endothelial damage in every tissue. There are SIRS and inflammatory effects which will cause chronic inflammation and tissue damage. And we know that there's thrombosis in the microvasculature of virtually every tissue in the body. So there is every significant neurological complication that is seen due to this pathology and adverse effects noted in every age group. Regarding brain fog and headache, we know that brain fog and headache are common symptoms. We know that headache exacerbations complicate function. In other words, because headaches appear to worsen after COVID-19 infection, other executive functioning abilities can become impaired. We know that the COVID-19 spike protein may be retained in the meninges and bone marrow of the skull. We know that there are structural brain changes with chronic COVID-19 infection that cause atrophy and cell damage. We note that there are also lung and hypoxic changes and blood flow effects that may exacerbate symptoms of brain fog and headache. These include attention disorders, fluency problems, memory, and processing gaps. It is good to note that there are reversible PET scan metabolic changes that are seen to occur over several months while a patient has long COVID, brain fog, and headache symptoms. And we know that there are at-risk groups who sustain greater PET changes, and greater attention can be made to assessing symptoms in these patients. Lastly, we note that there are both structural and functional changes in patients with COVID-19 brain fog and headache, and we know that some of these physiological changes are temporary, which means patients over several months can have restoration of a more optimal set of executive functions that allow them to cope day to day. Regarding long COVID, fatigue, and weakness, what do we conclude? We know that there are chronic deconditioning symptoms seen in these long COVID patients, and these symptoms are like those seen in myalgic encephalomyelitis, chronic fatigue syndrome, ME/CFS patients. These include fatigue, myalgias, depression, and poor restorative sleep. This is found to be related to mitochondrial dysfunction and chronic inflammation. Changes in the lungs and the brain both can cause a feeling of fatigue to be heightened. We know that this is in part related to macrophages and impaired muscle repair. We also note autonomic and cardiovascular dysfunction, noting that some patients with long COVID will have a resting tachycardia as a result. We know that there's a much greater rate of POTS, postural orthostatic tachycardia syndrome, in patients with ME/CFS and those with long COVID. And so we note that there is a multifactorial cause for feeling fatigued and weak when sustaining long COVID as a disease. Regarding chronic inflammation, we conclude the following. Some of this chronic inflammation is noted to be due to retained COVID-19 spike protein in the skull, bone marrow, and meninges. We know that there are autoantibodies that form in some long COVID patients. We see microthrombosis with local ischemia in most all tissues in the body. We observe chronic cardiovascular inflammation that can result in diseases such as POTS and other dysautonomias. And we note that there is chronic muscle inflammation and weakness in some long COVID patients. So we see that COVID-19 infection causes acute inflammation over time and a secondary inflammatory response that can last for months in some long COVID patients. These inflammatory responses are noted to cause what can be significant cardiovascular, chronic, autonomic effects such as POTS and dysautonomias. What do we conclude regarding the patient care of those with long COVID? It's important to accept dis-ease in patients with long COVID and the many symptoms that may occur in each individual patient. It's important to acknowledge multifactorial pathologies both when treating patients and discussing and educating patients about their long COVID disease. It is worthwhile to develop a holistic approach that is multi-pronged, that includes lifestyle changes, collection of data, medications, and accentuating important activities such as exercise and optimal sleep. Patients with long COVID should utilize rehabilitation strategies that can resolve the state of being deconditioned and can improve brain functioning and executive functioning with the use of rehab strategies that include exercise, sleep, and organized activities directed at improvements in mental health and attitude. It's important to adopt a scientific approach with patients for two reasons. One, if the patients can record what kind of symptoms they're experiencing, it may be possible for the clinician to assess and observe trends that might not otherwise be noted. This could lead to changes in therapies and optimizing patient outcomes. The second reason is if the patient becomes part of the clinical team, the individual patient will also then feel some sense of control over their disease as they attempt to resolve the long COVID symptoms over a matter of months to years. And it's important that patients and clinicians accept that reassessment intervals should be at longer time intervals, that is to say between major holidays and not from week to week. This is because the resolution of symptoms may plateau at several phases of recovery, and it's important to just note how the patient has improved over several months, not over several days or weeks. So when considering long COVID patient care, we know that long COVID can be life-changing and challenging. It's vexing, it's hard to understand, it's hard to figure out what is an optimal strategy, noting that for each individual patient, one individual strategy may prove to be superior to others in resolving symptoms. And physician and clinician input should provide greater patient understanding and education. As the patient understands more about their disease, they should be able to collect more scientifically rigorous data that will help the clinical team, and they should understand better what they need to do as an individual in order to feel better day to day and on an ongoing basis. Thank you for participating in this Fern educational session. You can find this video and others on our YouTube channel at Fern.org. Have a good day.